Dr. Niklas Luhmann. And actually, he's a medical doctor who is a Master of Science in International Public Health at University of Berlin and Copenhagen. And he has worked several years for the French humanitarian NGO, Médecins du Monde, on implementation research, healthcare system, infectious disease. He joins with the WHO headquarters in Geneva in 2019, and where actually he's working as a technical officer and leads the work on viral hepatitis B, D, and C prevention and testing. So I think it's the perfect speaker to start this webinar. So Niklas, please, the stage is yours.
Thank you, Maura. Can you just say if you can hear me? Apparently it's fine. Hello to everyone. Thanks for John and Lindsay and the Coalition for Global Hepatitis Elimination and ICE-HBV to have me at this important webinar for hepatitis delta. I will talk on epidemiology, cascade of care, and our recent recommendations. I work at the headquarters, if you have heard of WHO in Geneva. And thanks for joining here today. I just started, before I talk about epidemiology, I thought maybe there are some people who are still learning or starting to work on Delta. So just 3 bullets on a background, which is that hepatitis D virus is has been discovered in 1977 and is not as known as the other virus hepatitis strains. It really requires hepatitis B for packaging and release and transmission. So I think it's important to just, can everybody mute, please? To remind everyone that it can only infect people who have chronic hepatitis B as a super or co-infection, and its role in burden and morbidity and mortality, as stated by John, is as well underappreciated often by many. So in terms of epidemiology, the first thing I wanted to share, because as you now know, it can only occur as a super or co-infection of hepatitis B. Thus, I just wanted to quickly show from our recent access report that included data from around 180 countries, and that was released 2 months ago, the latest epidemiological estimates for hepatitis B, chronic hepatitis B, estimating 254 million people infected globally, with the main regions being the African and the both Asian regions affected here by chronic hepatitis B. Even maybe more importantly from this access report, possibly the main key message that came out is that we are estimating that mortality due to hepatitis B and C is slightly increasing. We're seeing now 1.3 million people dying every year from hepatitis B and C combined, with the main contribution coming from hepatitis B with 1.1 million annual deaths. And obviously this indirectly or directly includes the hepatitis delta death. And so this is a very important data point, which points to the fact that this might be the only communicable disease area where we have increasing mortality across the world. In terms of hepatitis delta epidemiology now, more focused on this, I'm here citing the systematic review and collaboration with the group from Alexander Stockdale and the 2020 publication, a global meta-analysis and systematic review that estimated that 4.5% among all people who live with surface antigen are positive for anti-HDV serology, and that was then calculated to be around 12 million people around the globe. That rate and prevalence was much higher in hepatology clinics. As many of you will know, there is some countries, and some are listed here, that are particularly affected with very high prevalence, and as well some groups that are disproportionately affected, including injecting drug users, hemodialysis recipients, men who have sex with men, commercial sex workers, and for example, those with Hep C or HIV infection. So this shows the map from this systematic review with the countries that included data points and the different estimates in the general population for anti-HBV serology prevalence in surface antigen positive people. And they estimated as well regional prevalence. And this one shows on the left in the red here in the general population, showing from 3 to 6% in the different regions. And suggesting that possibly the Afro and the Americas regions are those who might have the highest regional prevalence. This data set is now updated, and thanks a lot to Alexander Stockdale, who shared that with me. It has not been published yet at all. It's still all preliminary and has included more than 100 new updated searches. You can see on the right that there's been quite a good amount of new publications since 2019 and 2020. And again, this is preliminary and fully unpublished. He told me as well that he thinks that the general population prevalence may be coming out slightly lower with the new studies on a global level. And as many may know, it's really not always very evident to have good hepatitis delta prevalence estimates. This preliminary analysis from the same work will possibly show as well the population attributable fraction for cirrhosis in HCC, and pointing to the fact that delta contributes around 19.5% of cirrhosis cases in surface antigen positive people, and around 15% for HCC. So again, the contribution to cirrhosis and HCC is disproportional in some way from HDV. And if we relate that to the mortality figures that I've shown, I think that would really highlight that quite high number of people yearly die from hepatitis delta. We haven't done this particular sub-analysis yet at WHO. Another data set that I really like from Frédéric Legal, here focusing on Africa, shows, for example, here presented at AfroVIH 2020-40, that there's a huge amount of regional differences and a very strong concentration of high prevalence around the equatorial belt, for example, in the African subcontinent. And you can see even in countries such as Cameroon and Gabon, which are high prevalence, but huge regional differences, which points to the fact that there's regional, but even in-country strong differences in hepatitis delta prevalence. And there are really pockets of very high prevalence settings in certain countries, such as in Cameroon, for example. In terms of cascade of care, just a couple of slides. So again, I wanted to come back. I mean, if you think about the cascade of care, the first thing you have to do to find people with delta is you have to find people with chronic hepatitis B. And this doesn't show the cascade of care for delta. It shows the cascade of care for chronic hepatitis B from the same Access report, and noting that only 13% globally know their status for chronic hepatitis B. So there are regional differences, and some regions have a little bit higher rates, the Asian region, the European region, but really overall, there's a huge testing gap, and only once you know those people, you can then test for the presence of hepatitis delta serology. So closing this gap is crucial for closing the hepatitis delta cascade gap as well. In terms of the cascade, more specifically of delta, there's many studies that are shown in our guidelines, but as well in this paper from Stockholm, showing that historically, hepatitis delta testing in surface antigen people has been quite low to very low, depending on the setting, with some studies that I list here from Spain, from the US, and a little bit better testing rates in Greece. The cascade that you see below is the one from Stockholm that always had quite a good uptake of anti-HBV testing in this tertiary center. and that's a bit of an exception. But generally, one could say that, you know, even for those who know or who have been diagnosed with chronic hepatitis B, often hepatitis delta assessment has not been done. I think this is improving, at least in many countries, or in the European context. For example, we know studies from France. Here's one from Barcelona showing that this is improving, and notably using the reflex testing methodology and showing that, you know, prior and after reflex testing introduction, really a much higher proportion of people with surface antigen are tested for HDV serology, and then sometimes with double reflex testing as well for HDV RNA. So I wanted to finish with just showing our most recent hepatitis B guidelines that have now formal recommendations for delta testing and screening. So you can use that QR code if you want to go to the English guidelines. There's as well a link to the French policy brief of those guidelines. Before I show the recommendations, sorry, I will just drink a little bit. Before I show the recommendations, I like to always highlight the fact that WHO guidelines are a little bit different from other clinic society guidelines, for example, as in they're mainly targeting low and middle income countries. They're not only for treating clinicians, but as well national program managers that focus on a public health approach, and they're all completely evidence-based using the GRADE methodology. What was our rationale to developing now formal hepatitis delta testing and diagnosis recommendations? It was really, as I've shown already, the increasing understanding of the epidemiology, the contribution to morbidity and mortality, and the low testing and diagnosis proportions in people with chronic hepatitis B, and as well the need for improved surveillance, improved epidemiological data. We've been asked, obviously, why this update has not included recommendations for treatment, but it was felt, the expert group met last year, it was felt that there was not enough data yet on ideal dosing, ideal duration, and ideal and long-term outcomes from, for example, bulevirtide treatment. And we're monitoring this closely and thinking about when a recommendation can potentially be started. So the recommendations that we have developed is one on who to test. This is similar to the structure how we have made recommendations for hepatitis B and C, and there really recommends the universal testing approach as the preferred approach, stating that serological testing for anti-HDV antibodies may be performed for all individuals who are surface antigen positive. This is a conditional recommendation, and that means that it is recommended to do it that way, but it might be context-specific differences. And that's why we as well added an additional form of recommendation that states where really there are resource limitations to implement that, or laboratory capacity is not there. At the beginning, maybe countries can focus on specific populations that would include advanced liver disease patients, people with increased risk, or from high endemic countries or regions. The evidence for this didn't include any direct evaluations of impact or cost effectiveness, but the expert group discussed the findings from the observational studies from showing quite low uptake in risk-based approaches, and as well using some of the recent reflex testing, universal testing approaches. I just wanted, no, I will skip this. This will take maybe too long otherwise. The other recommendation is on how to test, and this is pretty standard and straightforward. The algorithm on the right is showing the recommendation that people may be diagnosed with hepatitis D by using a serological assay first, and then followed by a molecular assay to detect HDV RNA. And then we have developed as well a reflex testing recommendation for reflex testing for anti-HDV antibody testing, and potentially double reflex testing to reflex on to HDV RNA testing where available. That was based on a systematic review that included 11 studies, for which you find some key outcomes on the right there. And so the rationale for the reflex testing recommendation was really the substantially increased uptake for serology, but as well in some studies for the onward reflex for molecular testing, and the benefits outweighed clearly the harms was felt by the expert groups. So just to finish, this is my last slide. Some implementation considerations, they're pretty straightforward, include the fact that countries should develop policy and guidelines, procurement plans, and train their healthcare providers and laboratory staff, and have to as well develop some counseling and linkage to care mechanisms and monitoring and evaluation systems. This is the acknowledgement of the expert group for the hepatitis B guidelines with a Delta co-infection subgroup, for which you can see the members. And I'm staying on to receive any questions, and will monitor the chat as well if people have any questions. Thanks.